Hello, my name is Dr. Sunil Gupta and this is the second podcast on the Handbook of COVID-19 Prevention and Treatment published by Zhejiang University School of Medicine, China on the 18th of March 2020. This handbook is in 3 parts and this podcast covers part 2, diagnosis and management, and there are other podcasts which cover part 1, which is prevention and control management, and part 3, nursing. First, starting with the disclaimer, this PowerPoint is copied from the Handbook of COVID-19 Prevention and Treatment, written to experience of healthcare colleagues in China at a time when helpful information is urgently and desperately needed. Understandably, the handbook was written at great speed so that there is a possibility that there may be some errors and defects, and I would strongly recommend that you seek advice from your national profession for the latest evidence-based advice. So part 2, diagnosis management, is divided into 17 sections. 1, personalised, collaborative and multidisciplinary management. 2, etiology and inflammatory indicators. 3, imaging findings of COVID-19 patients. 4, application of bronchoscopy in the diagnosis and management of COVID-19 patients. 5, diagnosis and clinical classification of COVID-19 patients. 6, antiviral treatment for timely elimination of pathogens. 7, anti-shock and anti-hypoxemic treatment. 8, rational use of antibiotics to prevent secondary infections. 9, the balance of intestinal microecology and nutritional support. 10, ECMO support for COVID-19 patients. 11, convalescent plasma therapy for COVID-19 patients. 12, TCM classification therapy to improve curative efficacy. 13, drug use management of COVID-19 patients. 14, psychological intervention for COVID-19 patients. 15, rehabilitation therapy. 16, lung transplantation. And 17, discharge standards and follow-up plan for COVID-19 patients. So starting off with section 1, personalised, collaborative and multidisciplinary management. VIII is a designated hospital for COVID-19 patients, especially severe and critically ill patients whose condition changes rapidly, often with multiple organs infected and requiring the support from the multidisciplinary team, the MDT team. Since the outbreak, VIII established an expert team composed of doctors from the Departments of Infectious Diseases, Respiratory Medicine, ICU, Laboratory Medicine, Radiology, Ultrasound, Pharmacy, Traditional Chinese Medicine, Psychology, Respiratory Therapy, Rehabilitation, Nutrition, Nursing, etc. A comprehensive multidisciplinary diagnosis and treatment mechanism has been established in which doctors both inside and outside the isolation wards can discuss patients' conditions every day by video conference. This allows for them to determine scientific, integrated and customised treatment strategies for every severe and critically ill patient. Sound decision making is the key to MDT discussion. During the discussion, experts from different departments focus on issues from their specialised fields, as well as critical issues to diagnosis and treatment. The final treatment solution is determined by experienced experts through various discussions of different opinions and advice. Systematic analysis is at the core of MDT discussion. Elderly patients with underlying health conditions are prone to becoming critically ill. While closely monitoring the progression of COVID-19, the patient's basic status, complications and daily examination results should be analysed comprehensively to see how the disease will progress. It is necessary to intervene in advance to stop the disease from deteriorating and to take proactive measures such as antivirals, oxygen therapy and nutritional support. The goal of MDT discussion is to achieve personalised treatment. The treatment plan should be adjusted to each person when considering the differences among individuals, course of disease and patient types. I experience that MDT collaboration can greatly improve the effectiveness of the diagnosis and treatment of COVID-19. Now go on to section 2, etiology and inflammatory indicators. which is divided into subsection 1.0 detection of SARS-CoV-2 nucleic acid, 1.1 specimen collection, 1.2 nucleic acid detection, 2.0 virus isolation and culture, 3.0 detection of serum antibody, 4.0 detecting indicators of inflammatory response, 5.0 detection of secondary bacterial or fungal infections, 6.0 laboratory safety. 1.0 detection of SARS-CoV-2 nucleic acid, 1.1 specimen collection. Appropriate specimens, collection methods and collection timing are important to improve detection sensitivity. Specimen types include upper airway specimens, i.e. pharyngeal swabs, nasal swabs, nasopharyngeal secretions, lower airway specimens, i.e. sputum, airway secretions, bronchoalveolar lavage fluid, and other things like blood, feces, urine, and conjunctival secretions. Sputum and other lower respiratory tract specimens have a high positive rate of nucleic acids and should be collected preferentially. SARS-CoV-2 preferentially proliferates in type 2 alveolar cells, and peak of viral shedding appears 3 to 5 days after the onset of disease. Therefore, if the nucleic acid test is negative at the beginning, samples should continue to be collected and tested on subsequent days. 1.2 Nucleic acid detection. Nucleic acid testing is the preferred method for diagnosing SARS-CoV-2 infection. The testing process according to the kit instructions is as follows. Specimens are pre-processed and the virus is lysed to extract nucleic acid. The three specific genes of SARS-CoV-2, namely the open reading frame 1A/B, ORF1A/B, nucleocapsid protein, capital letter N, and envelope protein, capital letter E genes, are then amplified by real-time quantitative PCR technology. The amplified genes are detected by fluorescein intensity. Criteria of positive nucleic acid results are ORF1A/B gene is positive and or N gene/E gene are positive. The combined detection of nucleic acid from multiple types of specimens can improve the diagnostic accuracy. Among patients with confirmed nucleic acid in respiratory tract, about 30 to 40% of these patients have detected viral nucleic acid in the blood, and about 50 to 60% of patients have detected viral nucleic acid in feces. However, the positive rate of nucleic acid testing in urine samples is quite low. Combined testing with specimens from respiratory tract, feces, blood, and other types of specimens is helpful for improving the diagnostic sensitivity of suspected cases, monitoring treatment efficacy, and the management of post-discharge isolation measures. 2.0 Virus isolation and culture. Virus culture must be performed in a laboratory with qualified BSL-3. The process is briefly described as follows. Fresh samples of the patient's sputum, feces, etc. are obtained and inoculated on Vero E6 cells for virus culture. The cytopathic effect CPE is observed after 96 hours. Detection of viral nucleic acid in the culture medium indicates a successful culture. Virus titer measurement after diluting the virus stock concentration by a factor of 10 in series. The TCID50 is determined by the microcytopathic method. Otherwise, viral viability is determined by plaque forming unit. 3.0 Detection of serum antibody. Specific antibodies are produced after SARS-CoV-2 infection. Serum antibody determination methods include colloidal gold immunochromatography, ELISA, chemiluminescence immunoassay, etc. Positive serum specific IgM or specific IgG antibody titer in the recovering phase greater than or equal to 4 times higher than that in the acute phase can be used as diagnostic criteria for suspected patients with negative nucleic acid detection. During follow-up monitoring, IgM is detectable 10 days after symptom onset and IgG is detectable 12 days after symptom onset. The viral load gradually decreases with the increase of serum antibody levels. 4.0 Detecting indicators of inflammatory response. It is recommended to conduct tests of C-reactive protein, procalcitosin, ferritin, D-dimer, total and subpopulations of lymphocytes IL-4, IL-6, IL-10, TNF-alpha, INF-Y, and other indicators of inflammation and immune status which can help evaluate clinical progress, alert severe and critical tendencies, and provide a basis for formulation of treatment strategies. Most patients with COVID-19 have normal levels of procalcitosin with significantly increased levels of C-reactive protein. A rapid and significantly elevated C-reactive protein indicates a possibility of secondary infection. D-dimer levels are significantly elevated in severe cases, which is a potential risk factor for poor prognosis. Patients with a low total number of lymphocytes at the beginning of the disease generally have a poor prognosis. Severe patients have a progressively decreased number of peripheral blood lymphocytes. The expression levels of IL-6 and IL-10 in severe patients are greatly increased. Monitoring the levels of IL-6 and IL-10 is helpful to assess the risk of a progression to a severe condition. 5.0 Detection of secondary bacterial or fungal infections. Severe and critically ill patients are vulnerable to secondary bacterial or fungal infections. Qualified specimens should be collected from the infection site for bacterial or fungal culture. If secondary lung infection is suspected, sputum coughed from deep in the lungs, tracheal aspirates, bronchoalveolar lavage fluid, and brush specimens should be collected for culture. Timely blood culture should be performed in patients with high fever. Blood cultures drawn from peripheral venous or catheters should be performed in patients with suspected sepsis who have an indwelling catheter. It is recommended that they take blood G test and GM test at least twice a week in addition to fungal culture. 6.0 Laboratory safety. Biosafety protective measures should be determined based on different risk levels of experimental process. Personal protection should be taken in accordance with BSL-3 laboratory protection requirements for respiratory tract specimen collection, nucleic acid detection, and virus culture operations. Personal protection in accordance with BSL-2 laboratory protection requirements should be carried out for biochemical, immunological tests, and other routine laboratory tests. Specimens should be transported in special transport tanks and boxes that meet biosafety requirements. All laboratory waste should be strictly autoclaved. Now come on to section 3, imaging findings of COVID-19 patients. Thoracic imaging is of great value in the diagnosis of COVID-19, monitoring of therapeutic efficacy, and patient discharge assessment. A high-resolution CT scan is highly preferable. Portable chest x-rays are helpful for critically ill patients who are immobile. CT for baseline evaluation of patients with COVID-19 is usually performed on the day of admission, or if ideal therapeutic efficacy is not reached, it can be reperformed after 2 to 3 days. If symptoms are stable or improved after treatment, the chest CT scan can be reviewed after 5 to 7 days. Daily routine portable chest x-rays are recommended for critically ill patients. COVID-19 at the early stages often presents with multifocal patchy shadows or ground glass opacities located in the lung periphery, subpleural area, and both lower lobes on chest CT scans. The long axis of the lesion is mostly parallel to the pleura. Interlobular septal thickening and intralobular interstitial thickening displaying a subpleural reticulation, namely a crazy paving pattern, is observed in some ground glass opacities. A small number of cases may show solitary, local lesions or nodular/patchy lesion distributed consistent with bronchus with peripheral ground glass opacity changes. Disease progression mostly occurs in the course of 7 to 10 days with enlarged and increased density of the lesions compared with previous images and consolidated lesions with ear bronchogram sign. So, slide showing typical CT features of COVID-19 with figures 1 and 2 showing the patchy ground glass opacities. Figure 3 showing the nodules and patchy exudation. Figures 4 and 5 showing the multifocal consolidation lesions. And figure 6 showing diffuse consolidation, white lung. Critical cases may show further expanded consolidation with the whole lung density showing increased opacity, sometimes known as a white lung. After the condition is relieved, the ground glass opacities can be completely absorbed and some consolidation lesions will leave fibrotic stripes or subpleural reticulation. Patients with multiple lobar involvement, especially those with expanded lesions, should be observed for disease exacerbation. Those with typical CT pulmonary manifestation should be isolated and undergo continuous nucleic acid tests, even if the nucleic acid test of SARS-CoV-2 is negative. Now come on to section 4, application of bronchoscopy in the diagnosis and management of COVID-19 patients. Flexible bronchoscopy is versatile, easy to use and well tolerated in mechanically ventilated COVID-19 patients. Its applications include 1. Collection of respiratory specimens from the lower respiratory tract, i.e. sputum, endotracheal aspirate, bronchoalveolar lavage for SARS-CoV-2 or other pathogens guides the selection of appropriate antimicrobials, which may lead to clinical benefits. Our experience indicates that lower respiratory specimens are more likely to be positive for SARS-CoV-2 than upper respiratory specimens. 2. Can be used for the localization of the site of bleeding, cessation of hemoptysis, sputum or blood clots removal. If the site of bleeding is identified by bronchoscopy, local injection of cold saline, epinephrine, vasopressin or fibrin, as well as laser treatment, can be performed via the bronchoscope. 3. Assist in the establishment of artificial airways, guide tracheal intubation or precutaneous tracheotomy. 4. Drugs such as infusion of alpha interferon and acetylcysteine can be administered via the bronchoscope. Then there's a slide showing bronchoscopic views of extensive bronchial mucosal hyperemia, swelling, mucus-like secretions in the lumen, and jelly-like sputum blocking the airway in critically ill patients. So, figure 7, bronchoscopic manifestations of COVID-19, bronchial mucosal swelling and congestion, large amounts of mucus secretions in the lumen. Now come on to section 5, diagnosis and clinical classification of COVID-19. Early diagnosis, treatment and isolation should be carried out whenever possible. Dynamic monitoring of lung imaging, oxygenation index and cytokine levels are helpful for early identification of patients who may develop into severe and critical cases. A positive result of the nucleic acid of SARS-CoV-2 is the gold standard for the diagnosis of COVID-19. However, considering the possibility of false negatives in nucleic acid detection, suspected cases with characteristic manifestations in CT scans can be treated as confirmed cases even if the nucleic acid test is negative. Isolation and continuous test of multiple specimens should be carried out in such cases. The diagnostic criteria follows protocols for the diagnosis and treatment of COVID-19. A confirmed case is based on epidemiological history, including cluster transmission, clinical manifestations, i.e. fever and respiratory symptoms, lung imaging, and results of SARS-CoV-2 nucleic acid detection and serum-specific antibodies. So the clinical classification: 1, mild cases, the clinical symptoms are mild and no pneumonia manifestations can be found in imaging. 2, moderate cases, patients have symptoms such as fever and respiratory tract symptoms, etc., and pneumonia manifestations can be seen in imaging. 3, severe cases, adults who meet any of the following criteria: respiratory rate greater or equal to 30 breaths per minute, oxygen saturation less than or equal to 93% at a rest state, arterial partial pressure of oxygen PaO2 stroke oxygen saturation, oxygen concentration FiO2 less than or equal to 300 millimeters of mercury. Patients with 50% lesions progression within 24 to 48 hours in lung imaging should be treated as severe cases. For critical cases meeting any of the following criteria: occurrence of respiratory failure requiring mechanical ventilation, presence of shock, other organ failure that requires monitoring and treatment in the ICU. Critical cases are further divided into early, middle and late stages according to the oxygenation index and compliance of respiratory system. Early stage, an oxygenation index between 100 and 150 millimeters of mercury, compliance of respiratory system greater than or equal to 30 milliliters per centimeter of water, without organ failure other than the lungs. The patient has a great chance of recovery through active antiviral, anti-cytokine storm and supportive treatment. Middle stage, oxygenation index between 60 and 100 millimeters of mercury, compliance of respiratory system between 15 and 30 milliliters per centimeter of water, may be complicated by other mild or moderate dysfunction of other organs. Late stage, oxygenation index less than or equal to 60 millimeters of mercury, compliance of respiratory system less than 15 milliliters per centimeter of water, diffuse consolidation of both lungs that requires the use of ECMO, or failure of other vital organs, the mortality risk is significantly increased. Now come on to Section 6, Antiviral Treatment for Timely Elimination of Pathogens. An early antiviral treatment can reduce the incidence of severe and critical cases. Although there is no clinical evidence for effective antiviral drugs, currently the antiviral strategies based on the characteristics of SARS-CoV-2 are adopted according to the protocols for diagnosis and treatment of COVID-19, prevention, control, diagnosis and management. 1.0 Antiviral Treatment. At VIII, lopinavir, lopinavir, stroke ritonavir, ritonavir, 2 capsules given by mouth every 12 hours, combined with arbitol, arbidol, 200 milligrams by mouth every 12 hours, were applied as the basic regime. From the treatment experience of 49 patients in our hospital, the average time to achieve negative viral nucleic acid test for the first time was 12 days, 95% confidence interval 8 to 15 days. The duration of negative nucleic acid test result, negative for more than 2 times consecutively with intervals of greater than or equal to 24 hours, was 13.5 days with a 95% confidence interval of 9.5 to 17.5 days. If the basic regime is not effective, chlorquinine phosphate can be used on adults between 18 and 65 years old. If their weight is greater than or equal to 50 kilograms, the dose is 500 milligrams twice a day. If their weight is less than 50 kilograms, the dose is 500 milligrams twice a day for the first 2 days, then 500 milligrams once a day for the following 5 days. Interferon nebulization is recommended in protocols for diagnosis and treatment for COVID-19. We recommend that it should be performed in negative pressure wards rather than general wards due to the possibility of aerosol transmission. Darunavir, Darunavir, stroke cobicistat, cobicistat, has some degree of antiviral activity in viral suppression test in vitro based on the treatment experience of AIDS patients, and the adverse events are relatively mild. For patients who are intolerant to lopinavir, lopinavir, stroke ritonavir, ritonavir, then darunavir, darunavir, stroke cobicistat, cobicistat, 1 tablet QD, or favipiravir, favipiravir, starting dose 1600 milligrams followed by 600 milligrams TID, is an alternative option after the ethical review. Simultaneous use of 3 or more antivirals is not recommended. 2.0 Course of treatment. The treatment course of chlorquinine phosphate should be no more than 7 days. The treatment course of others have not been determined and are usually around 2 weeks. Antiviral drugs should be stopped if nucleic acid test results from sputum specimens remain negative for more than 3 times. Now come on to Section 7, Anti-shock and Anti-hypoxemic treatment. During the progression from severe to critically ill stage, patients may develop severe hypoxemia, cytokine cascade, and severe infections that might develop into shock, tissue perfusion disorders, and even multiple organ failure. Treatment is aimed at incentive removal and fluid recovery. The artificial liver support system, ALSS, and blood purification can effectively diminish inflammatory mediators and cytokine cascade and prevent the incidence of shock, hypoxemia, and respiratory distress syndrome. So it's divided into 1.0 use of corticosteroids when necessary, 2.0 artificial liver treatment for suppression of cytokine cascade, and 3.0 oxygen therapy for hypoxemia. 1.0 usage of corticosteroids when necessary. Appropriate and short-term use of corticosteroids to inhibit cytokine cascade and to prevent disease progression should be considered for patients with severe COVID-19 pneumonia as early as possible. However, a high dose of glucocorticoid should be avoided due to adverse events and complications. 1.1 Indications for corticosteroids. 1. For those in severe and critically ill stage. 2. For those with a persistent high fever, high temperature above 39 degrees Celsius. 3. For those whose CT demonstrated patchy ground glass attenuation or more than 30% of the area of the lungs are involved. 4. For those whose CT demonstrated rapid progression, more than 50% of the area involved in preliminary CT images within 48 hours. 5. For those with an IL-6 is above or great is equal to or greater than 5 ULN. 1.2 Application of corticosteroids. Initial routine methylprednisolone at a dose of about 0.75 to 1.5 milligram per kilogram intravenously once a day, nearly 40 milligrams once or twice a day is recommended. However, methylprednisolone at a dose of 40 milligrams every 12 hours can be considered for patients with falling body temperature or for patients with significantly increased cytokines under routine doses of steroids. Even methylprednisolone at a dose of 40 milligrams to 80 milligrams every 12 hours can be considered for critical cases. Closely monitor body temperature, blood oxygen saturation, blood routine, C-reactive protein, cytokines, biochemical profile, and lung CT every 2 to 3 days during the treatment as necessary. The dosage of methylprednisolone should be halved every 3 to 5 days if medical conditions of patients are improved, the body temperature normalizes, or involved lesions on CT are significantly absorbed. Oral methylprednisolone, Medrol, once a day is recommended when the intravenous dose is reduced to 20 milligrams per day. The course of corticosteroids is not defined. Some experts suggested ceasing corticosteroid treatment when patients are nearly recovered. 1.3 Special consideration during treatment. 1. Screening of TB by T-spot assay. HPV and HCV by antibody assay should be performed before corticosteroid therapy. 2. Proton pump inhibitors should be considered to prevent complications. 3. Blood glucose should be monitored. High blood glucose should be treated with insulin when necessary. 4. Low serum potassium should be corrected. 5. Liver function should be monitored closely. 6. Traditional herbal medicines may be considered. 7. Sedative hypnotics can be administered temporarily for patients with sleep disorders. Now come to artificial liver treatment for suppression of cytokine cascade. The artificial liver support system, ALSS, can conduct plasma exchange, adsorption, perfusion, and filtration of inflammatory mediators such as endotoxins and harmful metabolic substances of small or medium molecular weight. It can also provide serum albumin, coagulation factors, balanced fluid volume, electrolytes and acid-base ratio, and manifest anti-cytokine storms, shock, lung inflammation, et al. In doing so, it can also help to improve multiple organ functions, including the liver and the kidney. Thus, it can increase treatment success and reduce the mortality of severe patients. Indications for artificial liver support. So, patients meeting 1 and 2 or patients meeting criteria 3, where criteria 1 is serum inflammatory indicators such as IL-6 level rises to greater than or equal to 5 ULN, or rising rate is greater than or equal to 1 time per unit. Criteria 2 is involved area of pulmonary CT or X-ray images greater than or equal to 10% progression per day. And criteria 3 is artificial liver support system is required for the treatment of underlying diseases. So patients meeting either criteria 1 and 2 or patients meeting criteria 3 are indications for artificial liver support system. 2.2 Contraindications for artificial liver support system. There are no absolute contraindications in the treatment of critically ill patients. However, ALSS should be avoided in the following situations. 1. Severe bleeding disease or disseminated intravascular coagulation. 2. Those who are highly allergic to blood components or drugs used in the treatment process such as plasma, heparin and protamine. 3. Acute cerebrovascular disease or severe head injury. 4. Chronic cardiac failure, cardiac functional classification greater than or equal to grade 3. 5. Uncontrolled hypotension and shock. And 6. Severe arrhythmia. Plasma exchange combined with plasma adsorption or dual plasma molecular adsorption, perfusion and filtration is recommended according to the patient's situation. 2,000 milliliters of plasma should be exchanged when ALSS is performed. Detailed operating procedures can be found in the expert consensus on the application of artificial liver blood purification system in the treatment of severe and critical novel coronavirus pneumonia. ALSS significantly reduces the time that critically ill patients stay in the ICU in our hospital. Typically, the levels of serum cytokines such as IL-2, IL-4, IL-6, TNF-alpha are remarkably decreased and oxygen saturation is significantly improved after ALSS. 3.0 Oxygen therapy for hypoxemia. Hypoxemia can present due to impaired respiratory functions by COVID-19. Oxygen supplementation treatment can correct hypoxemia, relieving secondary organ damage caused by respiratory distress and hypoxemia. 3.1 Oxygen therapy, which is divided into 3.11 continual oxygen saturation monitoring during oxygen therapy, 3.12 oxygen therapy as soon as possible, 3.13 treatment goal of oxygen therapy, and 3.14 control oxygen therapy. 3.1 Oxygen therapy, 3.11 continual oxygen saturation monitoring during oxygen therapy. Some patients do not necessarily have impaired oxygenation functions at the onset of infection, but may manifest rapid deterioration in oxygenation over time. Therefore, continual monitoring of oxygen saturation is recommended before and during oxygen therapy. 3.12 Oxygen therapy as soon as possible. Oxygen therapy is not necessary for patients with oxygen saturation SpO2 of more than 93% or for patients without obvious symptoms of respiratory distress without oxygen treatment. Oxygen therapy is strongly recommended to the patients with symptoms of respiratory distress. It should be noted that some severe patients with PaO2/FiO2 less than 300 have no obvious symptoms of respiratory distress. 3.13 Treatment goal of oxygen therapy. The treatment goal of oxygen therapy is to maintain the oxygen saturation SpO2 at 93 to 96% for patients without chronic pulmonary disease and at 88 to 92% for patients with chronic type 2 respiratory failure. Specifically, the oxygen concentration should be increased to 92 to 95% for patients whose SpO2 drops below 85% frequently during daily activities. 3.14 Control oxygen therapy. PaO2/FiO2 is a sensitive and accurate indicator of oxygenation function. The stability and monitorability of FiO2 are very important for patients with disease progression and PaO2/FiO2 below 300 mm of mercury. Controlled oxygen therapy is the preferred treatment. High-flow nasal cannulae, HFNC oxygen therapy is recommended for patients with the following conditions: SpO2 less than 93%, PaO2/FiO2 less than 300 mm of mercury, where 1 mm of mercury is 0.133 kilopascals. Respiratory rate greater than 25 times per minute at bed, or remarkable progression on X-ray imaging. Patients should wear a surgical mask during high-flow nasal cannula treatment. The airflow of high-flow nasal cannula oxygen therapy should start at a low level and gradually increased up to 40 to 60 litres per minute when PaO2/FiO2 is between 200 to 300 millimeters of mercury, so that patients do not feel obvious chest tightness and shortness of breath. An initial flow of at least 60 litres per minute should be given immediately for patients with obvious respiratory distress. Tracheal intubation for patients is dependent on disease progression, systemic status, and compliance of patients for those, and complications of patients for those with stable disease but with low oxygenation index less than 100 millimeters of mercury. Thus, detailed evaluations of the clinical condition of patients is very important before decision making. Tracheal intubation should be performed as early as possible for patients with an oxygenation index less than 150 millimeters of mercury, worsening symptoms of respiratory distress, or multiple organ dysfunction within 1 to 2 hours after high flow, i.e. 60 litres per minute, and high concentration, i.e. greater than 60% HFNC oxygen therapy. Older patients greater than 60 years old with more complications or PaO2/FiO2 less than 200 millimeters of mercury should be treated in ICU. 3.2 mechanical ventilation, which is 3.21 non-invasive ventilation and 3.2 invasive mechanical ventilation, which is divided into principles of invasive mechanical ventilation in critically ill patients, lung recruitment, prone position ventilation, prevention of regurgitation and aspiration, fluid management, strategies to prevent ventilation-associated pneumonia, and weaning of ventilation. 3.2 mechanical ventilation, 3.21 non-invasive ventilation. Non-invasive ventilation is not strongly recommended in COVID-19 patients who fail HFNC treatment. Some severe patients progress to ARDS rapidly. Excessive inflation pressure may cause gastric distension and intolerance, which contribute to aspiration and worsen lung injury. A short-term, less than 2 hours use of non-invasive ventilation can be closely monitored if the patient has acute left heart failure, chronic obstructive pulmonary disease, or is immunocompromised. Intubation should be performed as early as possible if improvement of respiratory distress symptoms or PaO2/FiO2 is not observed. Non-invasive ventilation with a double circuit is recommended. A virus filter should be installed between the mask and the exhalation valve when applying non-invasive ventilation with a single tube. Suitable masks should be chosen to reduce the risk of virus spread through ear leakage. 3.22 Invasive mechanical ventilation. Number 1, principles of invasive mechanical ventilation in critically ill patients. It's important to balance the ventilation and oxygenation demands and the risks of mechanical ventilation-related lung injury in the treatment of COVID-19. Strictly set the tidal volume to 4 to 8 millilitres per kilogram. In general, the lower the lung compliance, the smaller the preset tidal volume should be. Maintain the platform pressure less than 30 centimetres of water. 1 centimetre of water is 0.098 kilopascals, and driving pressure less than 15 centimetres of water. Set PEEP according to the ARDS protocol. Ventilation frequency 18 to 25 times per minute. Moderate hypercapnia is allowed. Administer sedation, analgesia or muscle relaxant if the tidal volume, platform pressure and driving pressure are too high. Number 2, lung recruitment. Lung recruitment improves the heterogeneous distribution of lesions in patients with ARDS. However, it may result in severe respiratory and circulatory complications, and therefore the lung recruitment manoeuvre is not routinely recommended. The assessment of lung expandability should be performed prior to the application. Number 3, prone position ventilation. Most critically ill patients with COVID-19 respond well to prone ventilation with the rapid improvement of oxygenation and lung mechanics. Prone ventilation is recommended as a routine strategy for patients with PaO2/FiO2 less than 150 mm of mercury or with obvious imaging manifestations without contraindications. Time course recommended for prone ventilation is more than 16 hours each time. The prone ventilation can be ceased once PaO2/FiO2 is greater than 150 mm of mercury for more than 4 hours in the supine position. Prone ventilation while awake may be attempted for patients who have not been intubated or have no obvious respiratory distress, but with impaired oxygenation or have consolidation in gravity-dependent lung zones on lung images. Procedures for at least 4 hours each time is recommended. Prone position can be considered several times per day depending on the effects and tolerance. 4. Prevention of regurgitation and aspiration. Gastric residual volume and gastrointestinal function should be routinely evaluated. Appropriate enteral nutrition is recommended to be given as early as possible. Nasointestinal feeding and continuous nasogastric decompression are recommended. Enteral nutrition should be suspended and aspiration with 50 ml syringe be done before transfer. If no contraindication exists, a 30-degree semi-sitting position is recommended. 5. Fluid management. Excessive fluid burden worsens hypoxemia in COVID-19 patients. To reduce pulmonary exudation and improve oxygenation, the amount of fluid should be strictly controlled while ensuring the patient's perfusion. 6. Strategies to prevent ventilation-associated pneumonia. Ventilation-associated pneumonia bundled strategies should be strictly implemented. 1. Select appropriate type of endotracheal tube. 2. Use an endotracheal tube with a subglottic suction, once every 2 hours aspirated with 20 ml empty syringe each time. 3. Place the endotracheal tube at the right position and correct depth, fixed properly and avoid pulling. 4. Maintain the airbag pressure at 30 to 50 centimeters of water and monitor every 4 hours. 5. Monitor the airbag pressure and deal with water condensulates when the position changes, i.e. 2 people cooperate in dumping and pouring the water condensulates into a capped container containing a pre-made disinfectant chlorine solution. Deal with secretions accumulated in the airbag. 6. Clear up secretion from the mouth and nose timely. Weaning of ventilation. Sedatives is reduced and discontinued before awakening when the patient's PaO2/FiO2 is more than 150 mm of mercury. Intubation withdrawal should be performed as earlier as possible if permitted. High-flow nasal cannula or non-invasive ventilation is used for sequential respiratory support after withdrawal. Now come on to section 8, the rational use of antibiotics to prevent secondary infection. COVID-19 is a disease of viral infection, therefore antibiotics are not recommended to prevent bacterial infection in mild or ordinary patients. It should be used carefully in severe patients based on their conditions. Antibiotics can be used with discretion in patients who have the following conditions: extensive lung lesions, excess bronchial secretions, chronic airway diseases with a history of pathogen colonization in the lower respiratory tract, taking glucocorticoids with a dosage of greater than or equal to 20 milligrams for 7 days in terms of prednisolone. The options of antibiotics include quinolones, the second or third generation cephalosporins, beta-lactamase inhibitor compounds, etc. The antibiotics should be used for the prevention of bacterial infections in critically severe patients, especially those with invasive mechanical ventilation. The antibiotics such as carbapenems, CARBAPNEMS, beta-lactamase inhibitor compounds, linezolid, LINEZOLID, and vancomycin can be used in critically ill patients according to the individual risk factors. The patient's symptoms, signs and indicators such as blood routine, C-reactive protein and procalcitosin need to be closely monitored during the treatment. When the change of a patient's condition is detected, a comprehensive clinical judgment needs to be made. When the secondary infection cannot be ruled out, qualified specimen needs to be collected for testing by smear preparation, cultivation, nucleic acid, antigen and antibody in order to determine the infectious agent as early as possible. Antibiotics can be empirically used in the following conditions. 1. More expectoration, darker sputum colour, especially yellow pus sputum. 2. The rise of body temperature which is not due to the exacerbation of the original disease. 3. The marked increase of white blood cells and or neutrophils. 4. Procalcitosin greater than or equal to 0.5 nanograms per milliliter. 5. Exacerbation of oxygenation index or circulatory disturbance that are not caused by the viral infection and the other conditions suspiciously caused by bacterial infections. Some COVID-19 patients are at risk of secondary fungal infections due to weakened cellular immunity caused by viral infections, the use of glucocorticoids and or broad-spectrum antibiotics. It is necessary to do respiratory secretions microbiological detection such as smear preparation and cultivation for critically ill patients and provide timely D-glucose Ig test and galactomannan GM test, GLACTOMANNAN, which is the GM test, of blood or bronchoalveolar lavage fluid for suspected patients. It is necessary to be vigilant with possible invasive candidiasis infection and antifungal therapy. Fluconazole or echinocandin, ECHINOCANDIN, can be used in the following conditions. 1. Patients are given broad-spectrum antibiotics for 7 days or more. 2. Patients have parenteral nutrition. 3. Patients have invasive examination or treatment. 4. Patients have positive candida culture in the specimen obtained from 2 body parts or more. 5. Patients have significantly increased results of G-test. It is necessary to be vigilant with possible invasive pulmonary aspergillosis. Antifungal therapies such as voriconazole, VORICONAZOLE, posaconazole, POSACONAZOLE, or echinocandin, ECHINOCANDIN, are considered to be used in the following conditions. 1. Patients are given glucocorticoid for 7 days or more. 2. Patients have agranulocytosis. 3. Patients have chronic obstructive pulmonary disease and aspergillus culture are tested positive in the specimen obtained from the airway. 4. Patients have significantly increased results of GM test. Now come on to section 9, the balance of intestinal microecology and nutritional support. Some COVID-19 patients have gastrointestinal symptoms such as abdominal pain and diarrhea due to direct viral infection of the intestinal mucosa or antiviral and anti-infective drugs. There has been report that the intestinal microecological balance is broken in COVID-19 patients, manifesting a significant reduction of the intestinal probiotics such as lactobacillus and bifidium bacterium. Intestinal microecological imbalance may lead to bacterial translocation and secondary infection, so it's important to maintain the balance of intestinal microecology by microecological modulator and nutritional support. So 1. Microecologics intervention and number 2. Nutritional support. 1.0 Microecologics intervention. 1. Microecologics can reduce bacterial translocation and secondary infection. It can increase dominant gut bacteria, inhibit intestinal harmful bacteria, reduce toxin production, and reduce infection caused by gut microflora dysbiosis. 2. Microecologics can improve the gastrointestinal symptoms of patients. It can reduce water in feces, improve fecal character and defecation frequency, and reduce diarrhea by inhibiting intestinal mucosal atrophy. 3. The hospital with relevant resources can perform intestinal flora analysis. Therefore, the intestinal flora distribution can be discovered early according to the results. Antibiotics can be adjusted timely and probiotics can be prescribed. These can reduce the chances of intestinal bacterial translocation and gut-derived infection. 4. Nutrition support is an important means to maintain intestinal microecological balance. Intestinal nutrition support should be applied timely on the basis of effective evaluation of nutritional risks, gastroenteric functions, and aspiration risks. 2.0 Nutrition support. The severe and critically ill COVID-19 patient who are in a state of severe stress are at high nutritional risks. Early evaluations of nutritional risk, gastrointestinal functions and aspiration risks, and timely enteral nutritional support are important to the patient's prognosis. 1. Oral feeding is preferred. The early intestinal nutrition can provide nutritional support, nourish intestines, improve intestinal mucosal barrier and intestinal immunity, and maintain intestinal microecology. 2. Enteral nutrition pathway. Severe and critically ill patients often harbour acute gastrointestinal damages manifested as abdominal distension, diarrhea, and gastroparesis. For patients with tracheal intubation, intestinal nutrition tube indwelling is recommended for post-pyloric feeding. 3. Selection of nutrition solution. For patients with intestinal damage, pre-digested short peptide preparations, which are easy for intestinal absorption and utilization, are recommended. For patients with good intestinal functions, whole protein preparations with relatively high calories can be selected. For hyperglycemic patients, nutritional preparations which are beneficial to glycemic controlling are recommended. 4. Energy supply. 25 to 30 kilocalories per kilogram body weight. The target protein content is 1.2 to 2.0 grams per kilogram daily. 5. Means of nutritional supply. Pump infusion of nutrients can be used at a uniform speed, starting with a low dosage and gradually increasing. When possible, the nutrients can be heated before feeding to reduce intolerance. 6. The elderly patients who are at high aspiration risks or patients with apparent abdominal distension can be supported by parenteral nutrition temporarily. It can be gradually replaced by independent diet or enteral nutrition after their condition improves. Now we come on to section 10, ECMO support for COVID-19 patients. COVID-19 is a novel, highly infectious disease primarily targeting pulmonary alveoli, which damages primarily the lungs of critically ill patients and leads to severe respiratory failure. For the application of ECMO, that is extracorporeal membrane oxygenation, in COVID-19 treatment, medical professionals need to pay close attention to the following: the time and means of intervention, anticoagulant and bleeding, coordination with mechanical ventilation, awake ECMO, and the early rehabilitation training strategy of handling for complications. So ECMO support for COVID-19 patients is divided into 1. ECMO intervention timing, 2. Cathetering methods, 3. Mode selection, 4. Flux set value and target oxygen supply, 5. Ventilation setting, 6. Anticoagulant and bleeding prevention, 7. Weaning from ECMO and mechanical ventilation. 1.0 ECMO intervention timing. 1.1 Salvage ECMO, 1.2 Replacement ECMO, 1.3 Early Awake ECMO. So a disclaimer, please look at the original handbook rather than rely on figures in this podcast. 1.1 Salvage ECMO. In the state of mechanical ventilation support, measures such as lung protective ventilation strategy and prone position ventilation have been taken for 72 hours. With the onset of one of the following conditions, salvage ECMO intervention needs to be considered. 1. PaO2/FiO2 less than 80 millimeters of mercury, regardless of what the PEEP level is. 2. PPLAT less than or equal to 30 millimeters of mercury, PaCO2 greater than 55 millimeters of mercury. 3. The onset of pneumothorax, air leakage greater than a third tidal volume, duration more than 48 hours. 4. Circulation deterioration, the dosage of norepinephrine greater than 1 microgram per kilogram minute. 5. Cardiopulmonary resuscitation in vitro life support ECPR. 1.2 Replacement ECMO. When the patient is not suitable for long-term mechanical ventilation support, i.e. the patient is not able to obtain the expected results, ECMO replacement needs to be adopted immediately. With the onset of one of the following conditions, ECMO replacement needs to be considered. 1. Decreased lung compliance. After the pulmonary recruitment maneuver, the compliance of the respiratory system is less than 10 milliliters per centimeter of water. 2. Persistent exacerbation of pneumomediasternum or subcutaneous emphysema, and the parameters of mechanical ventilation support cannot be reduced within 48 hours, according to the estimation. 3. PaO2/FiO2 less than 100 mm of mercury, and it cannot be improved by routine methods in 72 hours. 1.3 Early awake ECMO. Early awake ECMO can be applied to patients who have been supported by mechanical ventilation with the expected high parameters for more than 7 days and who meet the necessary conditions of awake ECMO. They may benefit from it. All the following conditions must be met. 1. The patient is in a clear state of consciousness and is fully compliant. He or she understands how ECMO works and its maintenance requirements. 2. The patient is not complicated with neuromuscular diseases. 3. Pulmonary damage score Murray is greater than 2.5. 4. Few pulmonary secretions. The time intervals between the two airway suction procedures greater than 4 hours. 5. Stable hemodynamics. Vasoactive agents are not required for assistance. 2.0 Cathetering methods. Because the ECMO supporting time for most COVID-19 patients is greater than 7 days, the Scheldinger method should be used as much as possible for the ultrasound-guided peripheral catheter insertion, which reduces the bleeding, damages and infection risks brought about by intravascular catheterization by venous angiotomy, especially for the early awake ECMO patients. Intravenous catheterization by venous angiotomy may be considered only for the patients with bad blood vessel conditions, or the patients whose catheterization cannot be identified and selected by ultrasound, or the patients whose Scheldinger technique failed. 3.0 Mode selection. 1. The first choice for the patients of respiratory impairment is the VIII mode. The VA mode should not be the first option just because of the possible circulation problems. 2. For the respiratory failure patients complicated with cardiac impairment, PaO2/FiO2 less than 100 mm of mercury, the VAV mode ought to be selected with the total flux greater than 6 litres per minute and the V/A equal to 0.5 to 0.5 is maintained by current limiting. 3. For the COVID patients without respiratory failure but complicated with serious cardiovascular outcomes leading to cardiogenic shock, the VA assisted by ECMO mode ought to be selected. But IPPV support is still needed and the awake ECMO should be avoided. 4.0 Flux set value and target oxygen supply. 1. The initial flux greater than 80% cardiac output with a self-cycling ratio less than 30%. 2. SpO2 greater than 90% to be maintained. FiO2 less than 0.5 is supported by mechanical ventilation or the other oxygen therapy. 3. To ensure the target flux, the vein access cannula, which is first choice, is for people above 80 kilograms in weight is 22 FR, and people so people who are above 80 kilograms in weight is 24 FR, and those who are below 80 kilograms in weight, the first choice vein access cannula is 22 FR. 5.0 Ventilation setting. Normal ventilation maintenance by adjusting the sweep gas level. 1. The initial airflow is set to the flow to sweep gas equals 1:1. The basic target is to maintain PaCO2 less than 45 mm of mercury. For For the patients complicated with COPD, PaCO2 less than 80% basal level. 2. The patient's spontaneous respiratory strength and respiratory rate should be maintained, with a respiratory rate between 10 and 20 and without chief complaint of breathing difficulty from the patient. 3. The sweep gas setup of the VA mode needs to ensure that the pH value of the bloodstream out of the oxygenator membrane is 7.35 to 7.45. 6.0 Anticoagulation and bleeding prevention. 1. For the patients without active bleeding, without visceral bleeding, and with a platelet count greater than 50 times 10 to the 9 per litre, the recommended initial heparin dosage is 50 units per kilogram. 2. For patients complicated with bleeding or with platelet count less than 50 times 10 to the 9 per litre, the recommended initial heparin dosage is 25 units per kilogram. 3. The activated partial thromboplastin time, APPT, being 40 to 60 seconds, is proposed to be the target of anticoagulation maintenance dosage. The trend of D-dimer change should be considered at the same time. 4. Heparin-free operation may be performed in the following circumstances. The ECMO support must continue, but there is fatal bleeding or active bleeding that has to be controlled. Hold heparin-coated loop and catheterization with blood flow greater than 3 litres per minute. The recommended operation time less than 24 hours. Replacement devices and consumables need to be prepared. 5. Heparin resistance. Under some conditions of heparin usage, APTT is not able to reach the standard and blood coagulation happens. In this case, the activity of plasma antithrombin 3 needs to be monitored. If the activity reduces, fresh frozen plasma needs to be supplemented to restore heparin sensitivity. 6. Heparin-induced thrombopenia. When heparin-induced thrombopenia happens, we recommend to perform plasma exchange therapy or to replace heparin with agrotroban, ARGATROBAN. 7. Weaning from ECMO mechanical ventilation. 1. If a patient treated by VIII ECMO combined with a mechanical ventilation satisfies the awake ECMO condition, we suggest to first try to remove the artificial airway unless the patient has ECMO-related complications or the expected time of removal of all the assisting machines is less than 48 hours. 2. For a patient who has too much airway secretions that frequent artificial suction clearance is needed, who is expected to have a long-term mechanical ventilation support, who satisfies the conditions PaO2/FiO2 greater than 150 mm of mercury and time more than 48 hours, whose lung image changes for the better, and whose damages related to mechanical ventilation pressure have been controlled, the ECMO assistance may be removed. It is not recommended to keep ECMO intubation. We now come on to section 11, convalescent plasma therapy for COVID-19 patients. Since Behring and Kitasato reported the therapeutic effects of diphtheria antitoxin plasma in 1891, plasma therapy has become an important means of pathogen immunotherapy for acute infectious diseases. The disease progression is rapid for severe and critically ill patients of an emerging infectious disease. In the early phase, the pathogens damage the target organs directly and then lead to severe immunopathological damage. The passive immune antibodies can effectively and directly neutralize the pathogens, which reduce the damage of the target organs and then block the subsequent immunopathological damages. During multiple global pandemic outbreaks, World Health Organizations also emphasized that convalescent plasma therapy is one of the most recommended potential therapies, and it has been used during other epidemic outbreaks. Since the outbreak of COVID-19, the initial mortality rate was rather high due to the lack of specific and effective treatments. As mortality rate is an important metric that concerns the public, clinic treatments which can reduce the fatal rate of critical cases effectively are key to avoid public panic. At a provincial level hospital in Zhejiang province, we have been responsible to treat the patients from Hangzhou and critically ill patients of the province. There are abundant potential convalescent plasma donors and critically ill patients who need convalescent plasma treatment in our hospital. So 1.0 plasma collection, 1.2 clinical use of the convalescent plasma. 1.0 plasma collection. In addition to the common requirements of blood donation, the following details should be noted. 1.1 donors, at least 2 weeks after recovery and being discharged, either nucleic acid test of the sample taken from the lower respiratory tract remains negative for greater than or equal to 14 days, age between 18 and 55 years old, body weight more than 50 kg for men and greater than 45 kg for women, at least 1 week since last glucocorticoid usage, more than 2 weeks since last blood donation. 1.2 collection method, plasmapheresis 200 to 400 ml each time based on medical consultation. 1.3 post-collection testing. In addition to the general quality test and the test of blood-borne disease, the blood samples need to be tested for 1. Nucleic acid testing for SARS-CoV-2. Number 2. 160-fold dilution for the qualitative test for SARS-CoV-2 specific IgG and IgM detection, or 320-fold dilution for the qualitative test of whole antibody detection. If possible, keep more than 3 ml plasma for the viral neutralization experiments. The following should be noted. During the comparison of virus neutralization titer and luminescence IgG antibody quantitative detection, we found that the present SARS-CoV-2 specific IgG antibody detection does not fully demonstrate the actual virus neutralization capability of the plasma. Therefore, we suggested the virus neutralization test as a first choice, or test the overall antibody level with a 320-fold dilution of the plasma. (2.0) Clinical use of the convalescent plasma. 2.1 Indication. 1. Severe or critically ill COVID-19 patients tested positive in respiratory tract test. 2. The COVID-19 patients who are not severe or critically ill but in a state of immunity suppression or have low CT values in the virus nucleic acid testing but with a rapid disease progression in the lungs. Note, in principle, the convalescent plasma should not be used on COVID-19 patients with disease course exceeding 3 weeks, but in clinical applications we found that the convalescent plasma therapy is effective for patients with a disease course exceeding 3 weeks and whose viral nucleic acid tests continuously to show positive from respiratory tract specimen. It can speed up virus clearance, increase the numbers of the plasma lymphocytes and NK cells, reduce the level of plasma lactic acid and improve renal function. 2.2 Contraindication. 1. Allergy history of plasma, sodium citrate and methylene blue. 2. For patients with history of autoimmune system diseases or selective IgA deficiency, the application of convalescent plasma should be evaluated cautiously by clinicians. 2.3 Infusion plan in general. The dosage of convalescent plasma therapy is greater than or equal to 400 ml for one infusion or greater than or equal to 200 ml per infusion for multiple infusion. Now come on to section 12, which is TCM classification therapy to improve curative efficacy, and I suggest you see the handbook for advice based on traditional Chinese medicine. Section 13, drug use management of COVID-19 patients. COVID-19 patients are often complicated with underlying diseases receiving multiple types of drugs. Therefore, we should pay more attention to the adverse drug reactions and drug interactions so as to avoid drug-induced organ damage and improve the success rate of treatment. 1.0 Identification of adverse drug reactions. 2.0 Therapeutic drug monitoring. 3.0 Paying attention to the potential drug interactions. 4.0 Avoiding medical damage in special populations. 1.0 Identification of adverse drug reactions. It has been demonstrated that the incidence of abnormal liver function is 51.9% in COVID-19 patients who have received lopinavir, Lopinavir, stroke ritonavir, Ritonavir, combined arbidol, Arbidol, antiviral treatment. Multivariate analysis revealed that antiviral agents and more concomitant medications are two independent risk factors of abnormal liver function. Therefore, monitoring of the adverse drug reactions should be strengthened. The unnecessary drug combinations should be reduced. The main adverse reactions of antiviral agents include: number 1, lopinavir stroke ritonavir and darunavir stroke cobicistat, Cobicistat. Diarrhea, nausea, vomiting, the increase of serum aminotransferase, jaundice, dyslipidemia, the increase of lactic acids. Symptoms will recover after drug withdrawal. Number 2, arbitol, Arbitol. The main adverse drug reactions are the increase of serum aminotransferase and jaundice. When combined with lopinavir, Lopinavir, the incident rate is even higher. The symptoms will recover after drug withdrawal. Sometimes a slowdown of the heart could be induced, thus it's necessary to avoid the combination of arbitol with beta receptor inhibitors such as metoprolol and propranolol. We suggest to stop taking the drugs when the heart rate drops below 60 per minute. Number 3, fapiravir, Fapiravir. Elevation of plasma uric acid, diarrhea, neutropenia, shock, fumigant hepatitis, acute kidney injury. The adverse reactions were commonly seen in elderly patients or patients complicated with cytokine storm. 4, chloroquine phosphate. Dizziness, headaches, nausea, vomiting, diarrhea, different kinds of skin rash. The most severe adverse reaction is cardiac arrest. The main adverse reaction is the ocular toxicity. An ECG needs to be examined before taking the drug. The drug should be prohibited for patients with arrhythmia, e.g. conduction block, retinal disease or hearing loss. 2.0 Therapeutic drug monitoring. Some antiviral and antibacterial drugs need therapeutic drug monitoring, TDM. Table 1 presents the plasma concentrations of such drugs and their dosage adjustments. Upon the onset of aberrations of plasma drug concentration, the treatment regimes need to be adjusted by considering the clinical symptoms and concomitant drugs. So, Table 1 is the range of concentration and points for attention of the common TDM drugs for the COVID-19 patients. So for lopinavir, Lopinavir, and ritonavir, Ritonavir, you take the blood to measure the peak levels 30 minutes after drug administration, to measure the trough levels 30 minutes before drug administration. And for lopinavir, the range of concentration should be trough should be greater than 1 microgram per milliliter and peak should be less than 8.2 micrograms per milliliter. And the principles of dosage adjustment is correlated with drug efficacy and side effects. For impenem, Impen, EM, you measure the drug 10 minutes before you measure the drug level 10 minutes before the drug administration, and the range should be 1 to 8 micrograms per milliliter. And the principles of dosage adjustment are interpretation and adjust the plasma drug concentration based on the MIC of the pathogen testing. For meropenem, Meropenem, you measure the blood level 10 minutes before the drug administration. The range should be 1 to 16 micrograms per milliliter. And the principles for dosage adjustment is interpretation and adjust the plasma drug concentration based on MIC of the pathogen testing. For vancomycin, you do a blood level 30 minutes before the drug administration. The range of concentration is 10 to 20 milligrams per litre, and it's 15 to 20 milligrams per litre for the severe MRSA infection. Principles of dosage adjustment is the trough concentration correlates with the failure rate of anti-infective therapy and retinal toxicity. When the concentration is overly high, reduction of drug frequency or single dose is required. For linosolid, LINEZOLID. You measure the blood level 30 minutes before the drug administration. The range should be around about 2 to 7 micrograms per milliliter. And the principles of dosage adjustment is the trough concentration correlates with myelosuppression adverse effects. The blood routine test needs to be closely monitored. Then for voriconazole, VORICONAZOL, you measure the blood level 30 minutes before the drug administration. The range should be 1 to 5.5 micrograms per milliliter. And the principles of dosage adjustment is the trough concentration correlates with the therapeutic efficacy and adverse reactions such as impaired liver function. Paying attention to the potential drug interactions. Antiviral drugs such as lopinavir/ritonavir are metabolized through the enzyme CYP3A in the liver. When patients receiving concomitant medications, the potential drug interactions need to be carefully screened. Table 2 shows interactions between antiviral drugs and common drugs for underlying diseases. So Table 2, interactions between antiviral drugs and common drugs. So first, lopinavir and ritonavir, LOPINAVIR and RITONAVIR. The potential interactions are when combined with drugs associated with the CYP3A in metabolism, e.g. statins, immunosuppressors such as tacrolimus, voriconazole, the plasma concentration of the combined drug may increase, leading to increase of rivaroxaban of 153%, in atorvastatin 5.9-fold, and of midazolam of 13-fold. Pay attention to clinical symptoms and apply the TDM. So lopinavir and ritonavir are contraindicated to be given with drugs like amiodarone, where it can cause fatal arrhythmia, with quaternapine, where it can cause severe coma, with simvastatin, where it can cause rhabdomyolysis. Then you have darunavir, DARUNAVIR, cobicistat, COBICISTAT. Potential interactions is when combined with drugs associated with the CYP3A and or CYP2D6 metabolism, the plasma concentrations of the combined drugs may increase. So see comments with lopinavir and ritonavir. And it's contraindicated also with things like amiodarone, quaternapine and simvastatin for the same reasons. Next drug is Arbitol, ARBITON, ARBIDOL. Potential interactions are it interacts with CYP3A4 with UGT1A9 substrates, inhibitors and inducers. And in terms of contraindications, there's no relevant data available. Next drug is flapivir, FAPILAVIR. Potential interactions: 1. Theophylline increased the bioavailability of flapivir. 2. It increased the bioavailability of acetaminophen by 1.79-fold. 3. Its combination with pyrazinamide increased the plasma uric acid level. And 4. Its combination with repaglynide, REPAGLINIDE, increases the plasma repaglynide level. And in terms of where is flapivir absolutely contraindicated, the data is not available. And the final drug is chloroquine phosphate. And in terms of potential interactions, there's no relevant data available. And in terms of contraindications, prohibit using chloroquine phosphate combined with drugs which may lead to prolonged QT interval, things like azithromycin, amiodarone, and moxifloxacin, MOXIFLOXACIN. 4.0 Avoiding medical damage in special populations. Special populations include pregnant women, patients with hepatic and renal insufficiency, patients supported by mechanical ventilations, patients under continuous renal replacement therapy, CRRT, or extracorporeal membrane oxygenation, ECMO, etc. The following aspects need to be noted during drug administrations. 1. Pregnant women. lopinavir, lopinavir, stroke ritonavir, ritonavir tablets could be used, while flavipiravir, FAVIPIR, and chloroquine phosphate are prohibited. 2. Patients with hepatic insufficiency. Drugs that are excreted unchanged through the kidney are preferred, such as penicillin, cephalosporins, etc. 3. Drugs with renal insufficiency, including those on hemodialysis. Drugs that are metabolized through the liver or excreted through the liver-kidney double channel are preferred, such as lisosolid, LINEZOLID, moxifloxacin, MOXIFLOXACIN, caftrazone, etc. 4. Patients under continuous renal replacement therapy for 24 hours. For vancomycin, the recommended regime is loading dose 1 gram and maintenance dose 0.5 grams per 12 hours. For impenemin, IMIPEN, the maximum daily dosage should not exceed 2 grams. Now come to section 15, psychological intervention with COVID-19 patients. 1.0 The psychological stress and symptoms of COVID-19 patients. 2. Establishing a dynamic mechanism for evaluation and warning of psychological crisis. 3. Intervention and treatment based on the assessment. 1.0 The psychological stress and symptoms of COVID-19 patients. Confirmed COVID-19 patients often have symptoms such as regret and resentment, loneliness and helplessness, depression, anxiety and phobia, irritation and sleep deprivation. Some patients may have panic attacks. Psychological evaluations in the isolated wards demonstrated that about 48% of confirmed COVID-19 patients manifested psychological stress during early admission, most of which were from their emotional response to stress. The percentage of delirium is high among the critically ill patients. There is even a report of encephalitis induced by the SARS-CoV-2, leading to psychological symptoms such as unconsciousness and irritability. 2.0 Establishing a dynamic mechanism for evaluation and warning of psychological crisis. Patients' mental states are individual psychological stress, mood, sleep quality and pressure should be monitored every week after admission and before discharge. The self-rating tools include Self-Reporting Questionnaire 20, SRQ 20, Patient Health Questionnaire 9, PHQ 9, and Generalized Anxiety Disorder 7, GAD 7. The peer rating tools include Hamilton Depression Rating Scale, HAMD, Hamilton Anxiety Rating Scale, HAMA, Positive and Negative Syndrome Scale, PANSS. In such a special environment as the isolated wards, we suggest that patients should be guided to complete the questionnaires through their cell phones. The doctors can interview and perform scale assessing through face-to-face or online discussion. 3.0 Intervention and treatment based on the assessment. 3.1 Principles of intervention and treatment. For mild patients, psychological intervention is suggested. Psychological self-adjustment includes breathing relaxation training and mindfulness training. For moderate to severe patients, intervention and treatment by combining medication and psychotherapy are suggested. New antidepressants, anxiolytics and benzodiazepines can be prescribed to improve the patient's mood and sleep quality. The second-generation antipsychotics such as olanzapine and quetiapine can be used to improve psychotic symptoms such as illusion and delusion. 3.2 The recommendation of psychotropic medication in elderly patients. Middle-aged or elderly COVID-19 patients' medical situations are often complicated by physical diseases such as hypertension and diabetes. Therefore, when selecting psychotropic medications, the drug interactions and their effects on respiration must be fully considered. We recommend using citalopram, escitalopram, etc. to improve depression and anxiety symptoms. Benzodiazepines such as estalozlam, ESTAZOLAM, aprazolam, APRAZOLAM, etc. to improve anxiety and sleep quality, and olanzapine, quetiapine, etc. to improve psychotic symptoms. Now come to section 15, rehabilitation therapy for COVID-19 patients. Severe and critically ill patients suffer from different degrees of dysfunction. especially respiratory insufficiency, dyskinesia and cognitive impairment during both acute and recovery stages. 1.0 Rehabilitation therapy for severe and critically ill patients. 1.0 Rehabilitation therapy for severe and critically ill patients. The goal of rehabilitation intervention is to reduce breathing difficulties, relieve symptoms, ease anxiety and depression, and lower the incidence of complications. The process of early rehabilitation intervention is rehabilitation assessment, therapy, reassessment. 1.1 Rehabilitation assessment. Based on general clinical assessment, especially functional evaluation, including respiration, cardiac status, motion and ADL should be emphasized. Focused on respiratory rehabilitation assessment, which includes the evaluation of thoracic activity, diaphragm activity amplitude, respiratory pattern and frequency, etc. 1.2 Rehabilitation therapy. The rehabilitation therapy of severe or critically ill COVID-19 patient mainly includes position management, respiratory training and physical therapy. Number 1. Position management. Postural drainage may reduce the influence of sputum on the respiratory tract, which is especially important to improve the patient's VQ. Patients must learn to tip themselves into a position which allows gravity to assist in draining excretion from lung lobes or lung segments. For patients using sedatives and suffering from consciousness disturbance, a standing up bed or the bed head elevation 30 degrees, 45 degrees, 60 degrees may be applied if the patient's condition permits. Standing is the best body position for breathing in a resting state, which can effectively increase the patient's respiratory efficiency and maintain lung volume. As long as the patient feels good, let the patient take a standing position and gradually increase the time standing. Number 2. Respiratory exercise. 2. Chest expansion breathing combined with shoulder expansion. Increased pulmonary ventilation. When taking a deep, slow breath, one expands his or her chest and shoulders while inhaling and moves back his or her chest and shoulders while exhaling. Due to the special pathological factors of viral pneumonia, suspending breathing for a long time should be avoided in order not to increase the burden of respiratory function and the heart as well as oxygen consumption. Meanwhile, avoid moving too fast. Adjust respiratory rate at 12 to 15 times per minute. 3. Active cycle of breathing techniques. It can effectively remove bronchus excretion and improve lung function without exacerbation of hypoxemia and airflow obstruction. It consists of 3 stages: breathing control, thoracic expansion, exhalation. How to form a cycle of breathing should be developed according to the patient's condition. 4. Positive expiratory pressure trainer. The pulmonary institution of COVID-19 patients has been severely damaged. In mechanical ventilation, low pressure and low tidal volume are required to avoid damage to the pulmonary institution. Therefore, after the removal of mechanical ventilation, positive expiratory pressure trainer can be used to help the movement of excretions from the low volume lung segments to the high volume segments, lowering the difficulty of expectoration. Expiratory positive pressure can be generated through airflow vibration, which vibrates the airway to achieve airway supporting. The excretions can then be removed as the high-speed expiratory flow moves the excretions. 5. Physical therapy. This includes ultra-short wave, oscillators, external diaphragm pacemaker, electrical muscle stimulation, etc. Now come to section 16, lung transplantation in patients with COVID-19. Lung transplantation is an effective approach for final stage chronic lung disease. However, it is rarely reported that lung transplantation has been performed to treating acute infectious lung diseases. Based on current clinical practice and results, FASU summarizes this chapter as a reference for medical workers. In general, following the principles of exploration, doing the best to save life, highly selective and high protection. If lung lesions are not significantly improved after adequate and reasonable medical treatment, and the patient is in critical condition, lung transplantation could be considered with other evaluations. 1.0 pre-transplantation assessment, 2.0 contraindications. 1.0 pre-transplantation assessment. 1. Age. It's recommended that recipients are not older than 70 years old. Patients over 70 years old are subject to careful evaluation of other organ functions and post-operative recovery capability. 2. The course of the disease. There is no direct correlation between the length of the disease course and the severity of the disease. However, for patients with short disease courses, fewer than 4 to 6 weeks, a full medical assessment is recommended to evaluate whether adequate medication, ventilator assistance, and ECMO support have been provided. 3. Lung function status. Based on the parameters collected from lung CT, ventilator, and ECMO, it is necessary to evaluate whether there is any chance of recovery. 4. Functional assessment of other major organs. A. Evaluation of the consciousness status of patients in critical conditions using brain CT scan and EEG is crucial, as most of them would have been sedated for an extended period. B. Cardiac assessments including ECG and echocardiography that focuses on right heart size, pulmonary artery pressure, and left heart function are recommended highly. C. The levels of serum creatinine and bilirubin should also be monitored, for example with liver failure and renal failure. They should not be subjected to lung transplantation until the function of the liver and kidney are recovered. 5. The nucleic acid test of COVID-19. The patient should be tested negative for at least 2 consecutive nucleic acid tests with the time interval longer than 24 hours. Given the increased incidence of COVID-19 test results returning from negative to positive after treatment, it is recommended to revise the standard to 3 consecutive negative results. Ideally, negative results should be observed in all body fluid samples, including blood, sputum, nasopharynx, bronchial alveolar lavage, urine and feces. Considering the difficulty in operation, however, at least the test and sputum and bronchial alveolar lavage samples should be negative. 6. Assessment of infectious status. With the extended inpatient treatment, some COVID-19 patients may have multiple bacterial infections, and thus a full medical assessment is recommended to evaluate the situation of infection control, especially for multi-drug resistant bacterial infection. Moreover, post-procedural antibacterial treatment plans should be formed to estimate the risk of post-procedure infections. 7. The preoperative medical assessment process for lung transplantation in COVID-19 patients is a treatment plan proposed by the ICU team, leads to multidisciplinary discussion, leads to a comprehensive medical evaluation, leads to analysis and treatment of relative contraindications, leads to prehabilitation before lung transplantation. 2.0 Contraindications to lung transplantation. Please refer to the 2014 ISHLT consensus, a consensus document for the selection of lung transplantation candidates issued by the International Society of Heart and Lung Transplantation, updated in 2014. Now come on to Section 17, Discharge Standards and Follow-up Plan for COVID-19 patients. 1.0 Discharge Standards, 2.0 Medication after discharge, 3.0 Home isolation, 4.0 Follow-up, 5.0 Management of patients tested positive again after discharge. 1.0 Discharge Standards. 1. Body temperature remains normal for at least 3 days. Ear temperature is lower than 37.5 degrees Celsius. 2. Respiratory symptoms are significantly improved. 3. The nucleic acid is tested negative for respiratory tract pathogen twice consecutively, sampling interval more than 24 hours. The nucleic acid test of stool samples can be performed at the same time if possible. 4. Lung imaging shows obvious improvement in lesions. 5. There is no comorbidities or complications which require hospitalization. 6. SpO2 greater than 93% without assisted oxygen inhalation. 7. Discharge approved by multidisciplinary medical team. 2.0 Medication after discharge. Generally, antiviral drugs are not necessary after discharge. Treatment for symptoms can be applied if patients have mild cough, poor appetite, thick tongue coating, etc. Antiviral drugs can be used after discharge for patients with multiple lung lesions in the first 3 days after their nucleic acid are tested negative. 3.0 Home isolation. Patients must continue 2 weeks of isolation after discharge. Recommended home conditions are 1. Independent living area with frequent ventilation and disinfection to avoid contacting with infants, the elderly and people with weak immune functions at home. 3. Patients and their family members must wear masks and wash hands frequently. 4. Body temperature are taken twice a day in the morning and evening and pay close attention to any changes in the patient's condition. 4.0 Follow-up. A specialised doctor should be arranged for each discharged patient's follow-up. The first follow-up call should be made within 48 hours after discharge. The outpatient follow-up will be carried out 1 week, 2 weeks and 1 month after discharge. Examinations include liver and kidney functions, blood test, nucleic acid test of sputum and stool samples, and pulmonary function test or lung CT scan should be reviewed according to the patient's condition. Follow-up phone calls should be made at 3 and 6 months after discharge. 5.0 Management of patients tested positive again after discharge. Strict discharge standards have been implemented in our hospital. There is no discharge case in our hospital where sputum and stool samples are tested positive again in our follow-ups. However, there are some reported cases that patients are tested positive again after being discharged based on the standards of national guidelines, i.e. negative results from at least 2 consecutive throat swabs collected at interval of 24 hours, body temperature remaining normal for 3 days, symptoms significantly improved, obvious absorption of inflammation on lung images. It is mainly due to sample collection errors and false negative testing results. For these patients, the following strategies are recommended. 1. Isolation according to the standards of COVID-19 patients. 2. Continuing to provide antiviral treatment, which has been proved to be effective during prior hospitalisation. 3. Discharge only when improvement is observed on lung imaging and the sputum and stool are tested negative for 3 consecutive times with an interval of 24 hours. 4. Home isolation and follow-up visits after discharge in accordance with the requirements mentioned above. Summary. So this presentation was on part 2 of the handbook, which discussed diagnosis and treatment. There are other presentations on part 1, which is prevention and control management, and part 3, which is nursing. But I would strongly recommend that you actually look at the handbook, and a link to that is attached. Thank you for listening and watching.